to what you said that I'd like to add to your good start for us that participants should feel free to write in the chat box as we go along and questions come up. But those questions will not be answered until the end of the presentation, but please don't wait to put your questions in because you'll never remember an hour later. So I had several announcements to make before we start the webinar, and I get a chance to formally introduce our presenters. First one's about course quizzes. I just wanted to remind you to take the quiz after each webinar. Passing score is easily obtained because you have 3 tries for every question. I will be sending you, each of you, a list of the webinars and your quiz scores, which will tell you which quizzes you need to take and which ones need to be retaken in order to have an appropriate passing grade. Secondly, I'm wanting to talk to you further about what I've been calling bridge programming. Since the last week of this special training has been moved until the last week of next April, we have been working with the National AgriSafe Network to have good ways of keeping in touch with you during the next 5 months. This will include newsletters sent out to you by email, a combination one for November, December, and then January, February, and March. They will each contain information about a pertinent agricultural medicine topic webinar that you will be able to take, as well as information about additional assignments such as using AgriSafe's health risk assessment tool with a farm patient or client. Course textbooks will be mailed out to course participants, we hope, in early February when they finally arrive from the publisher. Thirdly, next week will be our final webinar on physical and environmental factors, vibrations, heat, cold, and noise, with Dr. Donham, Professor Emeritus at the University of Iowa College of Public Health Environmental Health Program, and Dr. John May, who until very recently has been the director of the Northeast Center for Agricultural Medicine and Health, who is a practicing pulmonologist. So there are your announcements for the week, and I wanted to hold up this so you know that the textbook can I make this work, actually exists. And so on to introductions. Dr. Christopher Grace is director of the Infectious Diseases Unit at UVM Medical Center. He received his MD from New York Medical College and did an internship in internal medicine at St. Vincent's Hospital in New York, followed by 2 fellowships, one in critical care at the University Health Center in Pittsburgh, and infectious diseases at St. Francis Hospital in Hartford, Connecticut. He has been an attending physician in infectious disease at the University of Vermont Medical Center since 1987 and director of the Infectious Disease Unit since 1992. Since 1994, he has also been the director of the HRSA grant for HIV care. Dr. Grace has received the UVM College of Medicine Clinical Teacher of the Year Award 4 times. And he is the author of 16 refereed journal articles and editor of Medical Management of Infectious Diseases, published in 2003. So, our second presenter is Jeffrey Heath, who is an RN. He is the Public Health Nurse Supervisor at the Middlebury District Office of the Vermont Department of Health. He is the epidemiology designee for the district and investigate cases of reportable diseases, partnering with the local hospital and medical providers to protect and promote public health for the Addison County service area. He has worked as a nurse for the Department of Health for 15 years and has, I love this line, through strong determination to promote health and prevent disease, he has become a trusted and reliable public health resource for his community. And he is very well thought of. And we are glad to welcome both of these experts to help us understand the complexities of vector-borne diseases today. Welcome to both of you. Dr. Grace, you're on.
Well, good afternoon and welcome, and speaking with my co-speaker, Jeffrey, we will present diseases that are spread by various insects, particularly ticks and mosquitoes here in the Northeast. Jeffrey and I will be going back and forth depending on the topic. And on the first slide there, you can see the topics that we're going to present. We're going to concentrate predominantly on Lyme disease and other infections that are spread potentially with Lyme disease, mostly because that is the most common. And then we will end up with a series of other very serious infections that cause predominantly brain infections, including West Nile virus, Eastern equine encephalitis, and Powassan virus. So I'm going to start off with 2 slides and just begin the discussion about Lyme disease. And Lyme disease is an illness that is caused by a bacteria called Borrelia burgdorferi. It is shown in the picture there. It is a spirochete when you look in the microscope, meaning that it is cork-shoe shaped like that and moves by twisting around. It is unique in several ways, different than other bacteria. The first is that it's able to change the outer proteins so that when our immune system sees it and develops an immune response to it, it can often dodge that immune response because it can change its outer surface proteins. Although it is a bacteria, it is very difficult to culture, and indeed in routine laboratories like in any of the clinical hospitals in the United States, we are unable to culture that. It can only be done in research laboratories. And then the organism does not in and of itself cause the symptoms of the disease, be it fevers or joint pains or meningitis, but it is our immunologic response to that bacteria that does that. This is a map of the world showing basically areas of Lyme disease. So 2 things to look at this. In the northern hemisphere in the United States, you can see that Lyme is caused by the Borrelia burgdorferi spirochete. You can see it's centered on the east coast and a little bit on the west coast, but those bacteria are spread by 2 different types of ticks that you will hear about in a moment. We will concentrate on the ones on the east coast. You can see, though, also all of Europe and Central Asia also has Lyme disease, but caused by different types of Borrelia, and they are transmitted by actually different tick species.
So I'm going to be talking about Ixodes scapularis. That is the black-legged tick, otherwise known as the deer tick, responsible for the transmission of Borrelia bacteria. I think that it's important to understand the life cycle of the black-legged tick for a couple of reasons. One, from a prevention standpoint, so the public and patients will understand where they might encounter ticks, when during the year they might be at higher risk, and also for providers to be able to relay that those prevention messages to their patients, and also to know when the high-risk times of year are, when to look for it, and to be able to identify it and treat it quickly, which is much better for patient outcomes. So in the spring of the first year, the female lays the eggs. The first stage is the larval stage. Now at this point in time, the tick is not carrying any pathogens, not infected with the Lyme disease bacteria. They are seeking a blood meal, usually a bird, a small mammal, a white-footed mouse, which is the reservoir, the main reservoir for the bacteria. If that mouse is infected with Borrelia and the larva takes the blood meal, then the larva would become infected. Now once the larva takes that blood meal, they molt into a nymphal stage, and then the nymphs go dormant and don't reemerge again until the following year. Now the following year, when the nymphs emerge, they will be looking for a second blood meal. And so they will, you know, if they attach to a person, a mouse, a dog, a deer, they will be seeking that blood meal. If they had become infected from their first blood meal, then they can obviously transmit the bacteria to a person at that point. Now it's important to know that nymphs are active in the peak of the summer months, so June, July, and August. They're very, very small, and they account for most of the human cases of Lyme disease. Even though they've only had one chance to become infected, they've only had that one blood meal. But because they're so small, they often go undetected, leaving the nymph time to feed and be attached long enough to transmit the Lyme disease bacteria. Once the nymphs take that second blood meal, they molt into adults. Now in the fall, the female adults will be looking for a third blood meal. They're much bigger, they're much easier to spot. If they don't get a blood meal in the fall, they will go dormant until the spring, and then at that point they will seek their third blood meal, and then lay their eggs, and then die. So the take-home message here is that nymphs account for most of the cases of human Lyme disease, and they are active in June, July, and August, peak summer months of the year. This slide shows the relative abundance of the three major stages of ticks. So as you can see, the green, well, I hope you can see the same color as I see, but the green bars are when the adults are active. The red bars are when the nymphs are active, and the blue bars are when the larvae are active throughout the year. As you can see, the adults are primarily active in the early spring and in the fall. And another thing to notice is that the nymphs are active before larvae are active. So, I mean, this is a pretty smart bacteria. So what that means is that nymphs can potentially infect a whole new generation of mice who will in turn infect the larvae when they feed. This is a graph that shows the number of Vermont cases of Lyme disease by month of onset from 2008 to 2011. And as you can see, the month of onset corresponds with when nymphs are the most active. So nymphs account for most of the human cases, even though they've only had one prior blood meal, only one chance to become infected with Borrelia. And again, it's because they're small and they're often unrecognized, so they are allowed to feed for greater than 24 hours. This is a picture of female black-legged ticks in various stages of engorgement. So on the left you have a female that has not begun to feed, and then as the female feeds, they become more and more engorged. Now this can be important for people, patients, for providers to know, because it kind of gives you an idea about how long a tick may have been attached to a person. If you find a tick on you and the tick is not engorged at all, then chances are it hasn't really been on that long. But if you have a tick on you and it's engorged like on the right, then you can be sure that it's been on there for quite a long time, and if that tick is carrying the Lyme disease bacteria, has probably transmitted it. We get this question a lot, you know, how come it takes so long for a tick to transmit disease? And I think this is a good visual for patients. The spirochete really hangs out in the tick's midgut. And ticks are very slow movers. They crawl, they take their time to attach to a person. They're very, very slow feeders. And so by 18 hours, blood is finally getting into the midgut where the spirochetes are located, allowing the spirochetes to begin to replicate. By 24 hours, the spirochetes have the ability to migrate to the tick's salivary glands, so still have not transmitted into a human or an animal. By 36 to 48 hours, then these spirochetes are able to be injected into the host. So there's 13 different species of ticks in Vermont, 4 of which are known to carry disease. And the 4 ticks that potentially carry disease in Vermont are listed there: the deer tick, the dog tick, woodchuck, and the Lone Star tick. Now, I just want to give you just a brief little history. We had to do a lot of work identifying ticks and testing ticks, because early on, Lyme disease and tick-borne diseases were really seen to be diseases that were obtained outside of Vermont. And there was a time when there was a disbelief that ticks were even in Vermont. So we had to do a lot of work collecting ticks, identifying them, testing them for Lyme disease. We had veterinarians involved. They were collecting ticks off of their patients, their canine patients. They were providing blood samples that we could do serology on to prove that they had been exposed to Lyme disease. We had combed deer during hunting season and collected those ticks and tested them. So it took some time to prove that yes, black-legged ticks are here. There are ticks in Vermont that transmit disease, and by far the most common disease carried by deer ticks is Lyme disease. Although we are seeing more cases of anaplasma, particularly in Bennington and Rutland County. Babesia we don't generally see in Vermont unless it's been obtained outside of Vermont. So I wanted to talk a little bit about our current tick surveillance project. It began a couple of years ago. Lyndon State College is the study lead, and they are doing surveillance at 12 sites around the state, 6 on either side. They collect ticks in the spring and the fall, at least once per site, and they test the ticks for Borrelia, Anaplasma, and Babesia. And this may be a little hard to see, but on the right you can see where the sites are located and the number of ticks that were tested at each site. And then on the left are the results of the 2-year study so far. And obviously not every tick tested was carrying pathogens, but the ones that were by far the most common was Borrelia. There were a very small number that tested positive for Anaplasma and none for Babesia. So this is showing the number of Lyme cases in Vermont. These are all Vermonters from 2002 to 2014. Now from 2002 to 2007, we were only collecting data on confirmed cases that were indigenous, that were obtained in Vermont, and cases that were either unknown where the person got Lyme disease or were known to have been imported. And starting in 2008, we started to collect information on probable cases as well. And as you can see, from 2007 to 2013, that there has been a steady increase in the number of reported cases of Lyme disease in Vermont. Now, this may be for a couple of reasons. One, there is probably more Lyme disease in Vermont, but I think too that there is a greater awareness. I think physicians are looking for it. They're very good at considering it as a diagnosis for the most part. But definitely we're seeing much more Lyme disease in Vermont. This compares the number of cases of Lyme disease in Vermont from 2005 compared to 2014. And as you can see on the left there, well, the bluer, the darker the color, the more number of cases per 100,000 population. And as you can see that there are some counties that had no cases at all, and then others that had very few in 2005. And then fast forward to 2014, that every county has been affected, and our southern counties are really bearing a higher burden. And then this is a national picture comparing 2001 to 2013. You can see this is the number of cases nationally. You can see in 2001 along the East Coast, and not really into Vermont or the rest of the Northeast. 2013, there's been a huge spread into Vermont, New Hampshire, and Lower Maine, over into New York State, and then again over in the Upper Midwest. There's been spread even in some of the northern central states. And then this is the age distribution for Lyme disease cases in Vermont from 2008 to 2011. As you can see, that 50 to 54 is the highest risk group. Actually, 50 to 64 is a very high risk age group. But then again, 5 to 14, there's a peak there too in terms of risk.
So once the tick bites you, it injects into your skin the bacterium, the Borrelia burgdorferi, and it will lodge in your skin and get into the macrophages there, and then start causing a systemic illness that goes through various phases that are outlined here. And I'll look in more detail on each of these phases, but these include early localized disease within days to weeks of the tick bite, to early disseminated disease from weeks to months after the tick bite, and then late disease generally from months to up to years. It could be that you may move directly from early localized disease with fevers and the classic skin rash right into early disseminated disease with heart problems, or you may not, and oftentimes these symptoms will resolve without treatment, but the spirochete is still in there and then can reemerge later if you are not treated. Same thing with early disease. Oftentimes those symptoms will go away on their own and then reoccur as later disease if you are not treated. And then the symptoms of late disease, classically arthritis that looks like rheumatoid arthritis, can come and go for years and years. So I'm going to step through each of these, and this is the first one. This is early localized disease characterized by constitutional symptoms and a rash referred to as erythema chronica migrans. This occurs at the tick bite, generally about a week or so after the bite. It has a long range of up to a month after the bite, and it occurs in most people, about 80%, but not in all. And particularly if it's on your back or the back of your thigh or whatever, you may not see it. It's not particularly painful, not particularly itchy, and it slowly expands over days to weeks. And that's a classic example of it up on the upper right-hand side. Please be aware that the majority of these rashes are homogeneous in nature. In other words, they are not bullseye lesions. They are diffuse redness that is red throughout the lesion. They are large, up to 20 centimeters, and ovoid or egg-shaped. You need to be careful not to mistake an erythema migrans rash with the damage from the tick bite itself. And the bottom picture is the tick bite lesion. You can get some redness there. You can get a little bit of bleeding from the tick bite. They generally do not hurt. But that is not erythema chronica migrans. These lesions from the tick bite are usually a centimeter or two in size, not the large ovoid redness. And here are some other pictures of this rash. You can see on the far right-hand side the classic bullseye lesion, but that is not the rule. The other ones that I show there are more characteristic of a ovoid rash with a sharp demarcation, and it is red throughout, occasionally a little bit of clearing in the center. So I think all the pictures that we are shown about to recognize Lyme disease show the picture on the far right with the bullseye lesion. That is the exception to the rule. So these are large, generally painless, generally not itchy, and there's really nothing else that looks like that. Early localized disease, in addition to the rash, generally is associated with constitutional symptoms that are there. You can have fatigue and headache and feverishness, and generally don't feel so well. Generally, patients don't get laboratory tests done, but if they do, they are usually very nonspecific, and there's no elevated white count that you see with other bacterial infections. The next phase is early disseminated. That is that the tick bit you, it injected the spirochete into your skin. The spirochete then gets into your blood, and it can disseminate throughout your entire body just like any other bacteria. And most commonly, if that is going to happen, we would see it as multiple erythema migrans rashes as shown here. And again, you can see these large ovoid pink to red blotches. Generally, again, they are not particularly painful or itchy, and they can be all over the place. Another manifestation of early disseminated disease is Bell's palsy. That is a facial palsy, as you can see in these young people, where the entire side of their face becomes paralyzed. It involves the upper and lower part of the face, and it can occur on both sides in about 25% of the patients, and it can take anywhere from weeks up to many months to resolve, even with appropriate therapy. In the middle is listed the differential diagnosis of a Bell's palsy. Mostly we think of this as herpes simplex virus induced, but I think in the summertime, as Jeffrey was saying, somebody comes into your office with a Bell's palsy, it is Lyme disease until proven otherwise. And then the other form, another form of early disseminated disease, again, early meaning weeks to months after the bite of the tick, is a meningitis. This looks just like viral meningitis. In other words, headache, some stiff neck, some photophobia, but the patient's mentation is normal. That is in contradistinction to the illnesses we'll talk at the end, which are encephalitic, meaning that the brain is infected. Here, the membranes around the brain are infected, so you have a terrible headache and fever, but you're thinking properly. If you CAT scan them or MR them, it'll be normal. And if you do a spinal tap, you will have a very classic sort of viral-like picture with predominant lymphocytes, elevated protein, normal glucose, and the gram stain is negative. If you send that fluid for a Lyme antibody, it is generally will be positive. Another early disseminated manifestation is radiculopathy. This is generally a unilateral involvement of the spinal nerve roots by the spirochete, causing pain or weakness or both. And so people can present with back pain, leg weakness if they get involvement in the lumbar area. Generally, though, when somebody comes in complaining of new onset pain, there's no history of injury that you would normally associate with back pain or leg pain. And if one did do imaging with an MR, it would be normal. So again, somebody presenting with new onset back, leg pain, or arm pain in a radicular pathway or associated with numbness in the summertime without trauma, this is Lyme disease. And then the sort of more serious early disseminated manifestation is atrioventricular block. This is an involvement of the atrioventricular nodes in your heart, and it blocks the transmission down to your ventricles, and so you go into complete heart block. And pulse rates can fall down into the 30s and 40s, and people will get symptomatic from that and present with lightheadedness or fainting, or since they're not pumping enough blood around, they may get short of breath or have chest pain. The bottom is an EKG showing someone in complete heart block. And on the right-hand column is looking at 875 patients from a certain study. About 10% of them had cardiac manifestations, so it's not all that common. And you can see a whole list of cardiac manifestations, including the conduction block at about 2%. At UVM, we see 2 or 3 cases like this every summer. And then late manifestations, meaning the onset of these symptoms months, if not years after the tick bite, if no treatment has been given, is classically arthritis. And indeed, Lyme was originally described in Lyme, Connecticut, when they thought they had an outbreak of rheumatoid arthritis in the population there. And they finally decided and figured out that this was due to the spirochete, but it can look like rheumatoid arthritis. That is a large, swollen, chronically swollen joint, classically the knee, and less likely the ankle and shoulder. It can begin abruptly, and it can last for a long time. These swollen joints, although can get very large with a lot of fluid, are not that painful. Certainly not as painful as other bacterial septic arthritis. If you tap their knee, they have an inflammatory response on average about 24,000 cells, but the culture will be negative. And then much less common, indeed very rare in the United States, but less so, a little bit more common in Europe, is an encephalomyelitis. That means that the spirochete has gotten up into the brain tissue and has caused an inflammation of the brain characterized by altered mental status, peripheral neuropathies, and so on. Lyme disease is treatable, and the slide shows what those therapies are. Mostly what you will be seeing is early localized and early disseminated. Again, these are the infections that you'll see in the spring, summer, and fall because they happen reasonably close to the tick bite when the ticks are out. Again, the drug of choice is doxycycline. Take it for 2 to 3 weeks, and know that spread is there because studies have been done using either 2 weeks or 3 weeks of therapy. If one cannot take doxycycline, it's a pregnant woman or a nursing mother, you can use amoxicillin or a second-generation cephalosporin, which is cefuroxime-axetil, or Zinacef. For the early disseminated disease and heart block, those people would be admitted to the hospital. We would treat them with a third-generation cephalosporin until their block goes away, which is usually only a couple of days. And then we'd switch over to oral antibiotics for another 3 weeks. The arthritis, which is into the later stages of Lyme, is again treated with oral doxycycline for a month. Acute meningitis, again occurring in the summertime, would be with intravenous ceftriaxone in order to get that into your brain, or penicillin. Generally, we treat for a month for that. And then for the very rare, at least in this country, encephalomyelitis, it would be antibiotics for 4 weeks. Now, these drugs work, but recovery is not always straightforward. Generally, the majority of people get better within 3 weeks. Occasionally, people can get what's called a Jarisch-Herxheimer reaction. That was first described when treating syphilis, which is another spirochete, with penicillin, and that is characterized by a high fever within several hours of the first dose of antibiotic. And that, since this is a spirochete, it is conceivable that that could happen also. Improvement, though, for some may be slow. And if you are more sick during your initial infection, you have disseminated disease or complex disease, you may take longer to get better. But there are a significant minority of people that will not feel well for 6 months or more with fatigue, what is referred to as brain fog, pain, and so on. The rash goes away, the heart blocks go away, and so on, but people just don't feel well. Eventually they will feel well in the vast, vast majority of people. And then the last bullet down there is, although you do develop an antibody response to this bacteria, it is possible to get reinfected if you get bit again. This is a complex slide that I'll walk through because this has to do with the immunologic reaction or your immune system's response to this bacteria. And this is true of any basic pathogen that you can bump into. So along the x-axis is time in weeks since the tick bite, which is down at the left-hand corner under the 0 time. Along the left-hand side is your antibody titer. Those are the immunoglobulin titers, if you would. And this represents a cartoon of what happens. So the first thing that you'll notice is that after the tick bites you at time 0, immunologically, nothing happens. You have generally a week or 2 or up to 3 weeks before you see any immune response happening. And therefore, even though you got bit by the tick and you have Borrelia burgdorferi in your body, the test that we use to test for antibodies will be negative. And that is a false negative test. You just have to be aware that if you're seeing somebody within, say, a week or 2 or 3 of the tick bite and their Lyme antibody test is negative, it does not mean they do not have Lyme. It just could be too early. Once your immune system kicks in, and this is true of any infection, if any of you have ever gone to the International Travelers Clinic, if you're traveling, you are told to come a month in advance before you travel. So when you get vaccines given, it takes sometimes 2 to 3 to 4 weeks for those vaccines to rev up your immune system. But the first thing that does happen is that you have an immunoglobulin or an antibody called IgM, and that first goes up, and that's an acute antibody response that will go up within generally 1 to 2, perhaps 3 weeks. It stays up for several weeks, and then it goes down. Oftentimes it will go down by 4 or 5 weeks, sometimes a little bit longer. Then, sort of at the same time, but much slower, is the long-acting permanent antibody titer, the immunoglobulin G. And that goes up slowly and then generally stays up chronically. And you can see that after 8 weeks, you have a dotted line there going into chronic disease, and that oftentimes will remain elevated forever. These antibodies are the ones that are being tested for when you order a Lyme test. The screening Lyme test that we'll talk about will look at all of those antibodies together, and then we divide them up looking for them individually by Western blotting. If after about 6 to 8 weeks your IgM antibody, which should have gone down, is still elevated, that is felt to be a false positive test. And we see this all the time where people have been sick with something for years and they have a positive IgM. That is not due to acute or ongoing Lyme. That is a false positive test. The reason being is that the molecule, the IgM molecule, is very sticky, and it tends to stick to the blotting systems easier and trigger a false positive test. This is the testing system that is used. It is referred to as a two-tiered testing. This is the exact process that we use to test for HIV. So you order an HIV test, this is exactly how it's done. This is the testing process that is recommended by the FDA, the NIH, state and territorial epidemiologists, the society I belong to, the IDSA. Basically everybody within reason supports this two-tiered process. And it starts by doing a general, very sensitive test called an EIA that tests any antibodies that are in your body against any type of antigen that the bacteria could have. The reason that is used that it's very sensitive. So we want to make sure that if you do have Lyme disease, that it'll be caught. The problem with a very sensitive test is that some of those tests are false positives, and so we can then confirm that with a Western blot. And those are much more specific, and those are confirmatory tests, and they look for how many antibodies you have to various parts of the bacteria via the IgG and the IgM and this criteria that CDC put out. If the screening ELISA up at the top is negative, that's the end of that. We don't do Western blotting beyond that. If the screening EIA or ELISA is positive, we would then do Western blotting for that. If the Western blot is negative, the entire test is negative. If the ELISA or the EIA is positive and the Western blot is positive, then that's a positive test. But you have to have both steps that are positive. How good is this test? There's a lot of controversy out there, but this is one of numerous studies that have been done looking at that. And you can see at the very top of the chart, there's the erythema migrans. That's the early stages. And then you can see the acute neurologic or carditis phases. Those are early disseminated. And then you can see late stages of disease with the arthritis and so on. And you can see that in all of these phases, particularly with the latter stages of arthritis, meaning that somebody has been ill for a month or two or up to years, that virtually all of those tests are positive. And the Institutes of Medicine have looked at these tests and felt that these are extremely sensitive and specific tests approaching 100% accuracy. So, going to switch around a little bit and look at some controversial areas that you will certainly bump into. So the first is that one has chronic symptoms and after treatment are attributed those symptoms to ongoing active bacterial infection. In other words, the belief that the spirochete is still active in your body despite being treated. So following along on the left-hand side, you have Lyme disease, you get treated, and you still don't feel well. These are mostly subjective symptoms: fatigue, pain, cognitive impairment, the brain fog, if you would. There is nothing measurable. Physical exam is normal, laboratory tests are normal, and so on. And so these are ongoing subjective symptoms. These symptoms are not chronic active spirochete infection or Borrelia infection. There's no evidence that the Borrelia is there, and this is referred to as the post-Lyme treatment syndrome, which can occur in 25% or so people, can last for months, sometimes longer than 6 months. In the vast majority of people, it eventually goes away. But this brings up a lot of questions. It says, you know, how common are these symptoms? Are the spirochetes really still alive? Do prolonged antibiotics help? Because you will hear or see people going on very long courses of antibiotics. And if this is not due to an infection, then what does it do to? So we'll take a very brief look at each of these topics. So the first question is, after you have been treated, are there live Borrelia burgdorferi spirochetes in your body? And the answer to that is no. And that is not for a lot of looking for these spirochetes. And in animal studies, which are a little bit easier to dissect and get tissue samples for to look for these, that after animals have been infected with the Borrelia and treated with antibiotics, the organism cannot be found in these animals, even if they are very, very immunosuppressed. In humans, before they are treated, you can culture, in a research laboratory, you can culture the spirochete from skin lesions. After treatment, you cannot find them. And then, and I'll quote one of these studies in a moment, but a large number of studies have been done looking at a lot of different issues, particularly treatment, but a lot of samples have been drawn from blood, spinal fluid, skin, and so on, looking for these organisms after treatment, and they can't find it. And they've looked hard. And the National Institute of Allergy and Infectious Disease said they do not believe that the spirochete remains inside you as a live bacteria. And therefore, using more antibiotics, even if you don't feel well, don't work. What is, though, the post-treatment ongoing symptoms due to in some of these people? And I don't think anybody really knows for sure, but I think people are going in the direction that this is an immunologic reaction to the spirochete, which is gone. It's similar to your body reacting to certain antigens that cause rheumatoid arthritis or systemic lupus. And what you have here on the top graph is a measurement of a cytokine called IL-23. That's an acute inflammatory cytokine that goes up with inflammation. And on the far right-hand side, you can see healthy controls that the level of that cytokine is very low. In the middle part of that are people who had Lyme disease but did not have the sort of post-treatment ongoing symptoms. Again, relatively low levels of this cytokine, while those people who have had Lyme disease got treated but continue not to feel well, those cytokine levels are quite a bit higher. And the bottom graph then is looking at what happens over time. And again, you can see over 12 months of time, the top bars, if you would, in black dots, are showing those people who have post-treatment symptoms ongoing have much higher levels of these cytokines. So this suggests that your body has seen the spirochete, the antibiotic has killed it, but your body is still immunologically reacting to it in somewhat of a dysregulation way. It's not proven, but this is how people are leaning. Do antibiotics, prolonged antibiotics, improve symptoms? In other words, does anything more than, say, 2 to 3 weeks of antibiotics really help you? There have been 4 randomized placebo-controlled trials done. This is sort of the gold standard of how we test drugs, and this is one of them. So they took a cohort of people who had been treated multiple times over many years and were still feeling ill with presumed ongoing bacterial infection causing their symptoms. And they randomized them to either use intravenous ceftriaxone for a month and then an additional 2 months of doxycycline, or placebo. And again, these were blinded, and they followed these folks through, and they did measurements of how much pain they were having, what their cognitive functioning was doing, measuring their fatigue levels. And at the end of the study, there was no difference between those that received antibiotics and those that received placebo. And this study or similar studies have been repeated on multiple occasions with the same outcomes. No difference. What they did see was that those people who got antibiotics, about 25% of them, actually had some serious complications from the antibiotics. The pulmonary embolism is from the PICC line that you use to administer the ceftriaxone, fevers, anemia, rashes, and so on. So these antibiotics are not benign and they do not help. And then what about starting from the other direction, that somebody comes into your office and says, I just feel terrible. I'm fatigued, I have chronic pain, I have brain fog, and I think this is due to Lyme disease with no history of tick bite, no history of rashes, no history of anything. And oftentimes, even if the Lyme test is negative, patients and some doctors will attribute those symptoms to Lyme disease and start treating. Or even if that person has a positive Lyme test, say, well, that Lyme is causing those symptoms. And that gets into some difficult areas. And for those of you who are in practice, you'll recognize the next slide, but how common are these symptoms in the general population of people coming in with pain, fatigue, cognitive impairment? And you can't say that all of that is due to Lyme disease. And this is a compilation of various studies that have been done both here in the United States, population studies by survey. 20 to 30% of the adult population complaining of chronic fatigue. Widespread chronic pain, 11%. Emotional or severe cognitive dysfunction, 2 to 3%. Numbers of reported unhealthy day in the preceding month, 6 days, 6 out of 30 days. Self-reported health status in 4,000 individuals in the United States, severe pain up to 10%. Moderate pain up to 45%, and 25 to 33% had chronic cognitive dysfunction in my survey. So these are very, very common symptoms in our population here in the United States, and people then try to say that's due to Lyme disease, and you've got to be very careful doing that. Along the same lines, that overdiagnosing Lyme disease is dangerous. Underdiagnosing Lyme disease is dangerous and can lead to a lot of problems, and we see that. And so I'm pleased that this educational forum is going on. But overdiagnosing Lyme disease is also dangerous. This is a study from the Yale Lyme Disease Clinic in Connecticut, looking at 209 people who were either self-referred or referred by their doctor for Lyme disease. And these experts in Lyme disease felt that 44 of them had active Lyme disease, meaning that they had an erythema migrans rash, or they had been treated. But out of that 209 people, they felt that 125 of them did not have Lyme disease. They had fevers, myalgias, joint pains, but they did not feel that they had Lyme disease by history, physical, or laboratory testing. Yet these people went through an immense amount of things. On the far left-hand box in the yellow, 232 courses of antibiotics, average of 4 doctor visits because of these symptoms, innumerable tests, and then all these people went on antibiotics by their primary docs or their providers. Up to 55% had a, quote, minor reaction to the antibiotic. There could be rash, diarrhea, nausea, vomiting, yeast infections. If you have them, they're not so minor. And about 6% had serious reactions, including septic thrombophlebitis from the PICC line, neutropenia from these antibiotics, or what scares me the most with these drugs is Clostridium difficile enterocolitis. So this, when one gives thought of, well, somebody has fatigue and brain fog, or they're achy and I'm going to give them an antibiotic just in case they have Lyme disease, be sure that you don't hurt somebody doing this. So switching gears a little bit, the tick that is transmitting the Lyme bacteria, the Borrelia, as Jeffrey said, can transmit other pathogens at the same time. And those are listed here, the Anaplasma, the Babesia. There's a new Borrelia species that has been identified, and then we'll talk a little bit later briefly about Powassan virus. As you saw from the slides that Jeffrey showed, Anaplasma is in Vermont. It's still quite rare, and Babesia is not here yet. Will it get here in the future? Don't know, but mostly that is out in Rhode Island and Cape Cod area, so it's important to get a travel history. If somebody is infected with Babesia, Lyme disease, and one of these things, oftentimes they are more sick, higher fevers, more prostrate, and they can be ill for longer than one would expect, even after antibiotics. Or that the erythema migrans rash goes away as it would normally, even without treatment, but they continue to be ill. So Anaplasma is a bacteria. Again, it's impossible to grow in the routine laboratory, and it's very difficult to see on microscopy. That arrow looking at a blood smear is showing these vacuoles with the bacteria in them, but we've seen those a couple times, but usually you don't see stuff like that, so it's really difficult to pick up on diagnosing an Anaplasma. The tricks or the things that you might think of or look for would be thrombocytopenia and leukopenia as the biggest thing. So if you have somebody come in and they're sicker than you would expect them to be, higher fevers and so on, particularly if you get a blood count and they're anemic or thrombocytopenic or leukopenic, that's where you think of Anaplasma. Fortunately, Anaplasma the treatment for that is the same antibiotic as for Lyme disease, doxycycline. So if your patient is able to use doxycycline and you treat them, then this will knock off the Anaplasma, and that's good. If you cannot, and you have to use ampicillin or cefuroxime, and your patient is sick, then you should look for this organism by polymerase chain reaction, and that's a send out.
So we have been doing surveillance in Vermont for Anaplasma since 2010. This slide shows the number of Anaplasma investigations that have been conducted. As you can see, that it includes confirmed cases, probable cases, and then cases that were not cases at all. Now the 2010 through 2014 are year-end totals for the entire year. The 2015 is just through July 11th of this year. But as you can see, the number of confirmed cases have steadily increased. The number of probable cases have steadily increased. And then this is comparing last year to this year, the number of investigations through week 27. So last year at that point in time, we had done 42 investigations resulting in 16 confirmed and 10 probable. In that same period of time in 2015, we had done 106 investigations with 48 confirmed and 15 probable. And I checked as of September 22nd of this year, 90 total confirmed and probable cases had been identified in Vermont, with 59 from Bennington County, 19 from Rutland County, and the rest were very sporadic throughout the rest of the state.
The other organism that can be transmitted with the deer tick is Babesia microti. This is a protozoa that looks like malaria, and the picture up at the far right-hand side is a blood smear showing these circular parasites in the blood, and at a quick look they look just like malaria. It is very rare so far in Vermont, and that one case I'm aware of was blood transfusion related. So we are not looking for it at a whole lot for a moment. Where you might think about it is somebody, again, coming in with what you think is Lyme disease, but they have more severe disease. They have a hemolytic anemia because this organism will slice open the red blood cells just like a malaria parasite will, thrombocytopenia, and maybe hepatosplenomegaly just like in malaria. Generally, it is self-limited and will resolve on its own. It can be severe. The diagnosis is the same way that you would diagnose malaria. You'd send off a blood smear, and the laboratory techs would look for it, looking for those ring forms. You can also send off for PCR. Be careful of sending off serology. Again, this may just denote previous exposure and not active disease if it is positive. There's very good treatment, as listed there, and a bunch of drugs we don't use too often, but we can certainly treat this if it is diagnosed.
So switching gears, we want to turn to prevention measures. Obviously, preventing Lyme disease is the ultimate goal, with early identification and treatment as equally important. So I want to talk about preventing Lyme disease. The best way is to prevent tick bites. And we're also talking about other tick-borne diseases as well. So I'd like to talk about some personal prevention measures that can be taken, some environmental landscaping strategies that can be done homeowners and at the community intervention level. And it's really a combination of strategies that work best. And honestly, with good awareness and good prevention strategies, you can do a pretty good job in preventing tick bites. So it's important to know where ticks are, where they hang out, where their habitats are, and to avoid them. And if you can't avoid them, then to take personal protective measures while you're in a tick habitat. Now, they don't fly, they don't jump, they don't run, they crawl. And in fact, the picture in the upper right is often where you will find them. They're on the tips of blades of grass. Oftentimes they're just waiting there for a mouse or a deer or a person to go by where they can hitch a ride on and then look for exposed skin to get a blood meal. So they quest. They are really just hanging out waiting for you or an animal to come along. So they like the tall grass, they like brushy areas, they need a certain level of moisture and humidity, so leaf litter, wood piles near stone walls. It doesn't mean that you can't go hiking. I'm certainly not suggesting that people can't go into the woods and people can't recreate in Vermont, but you have to take the proper precautions. So keeping to the center of the trail and hiking, you're going to be far less likely to encounter a tick versus hiking off trail where you're brushing up against lots of tall grass, brush, etc. So if you do need to go into a habitat where ticks are, then you want to use some protective clothing. And so it's recommended to wear light-colored clothing. And the reason for this is because it's easier to spot a tick on light-colored clothing. Particularly the nymphal stage ticks, which can be just as big as a poppy seed, a speck of dirt. They're much more easy to identify. Using barriers, tucking your pants into your socks. Now, you don't need to do that if you're going, from your home to the grocery store. But if you're going out to work in your garden, or if you're going to walk in the fields to pick flowers or hike in the woods, then you're going to want to do that. And tucking your shirt into your pants, having the least amount of exposed skin as possible. Having proper footwear, not wearing sandals when you're walking in the woods, even with socks on. Ticks can get through even a tight weave sock. And then thinking about long hair. Long hair can brush against shrubs. They can brush against grass if you're sitting on the ground, and ticks can hitch a ride that way. And what I often say to people is really to think, when you're thinking about all these prevention measures, is to, depending upon what you decide to do or what you're going to be doing, is to determine your risk and then take appropriate action. So if you're going hiking, then you're going to want to use a combination of these methods. But if you're not, and you're going to be walking on a concrete sidewalk, then you know you're going to be at far less risk in that situation. So determine your risk and then take appropriate action. So insect repellents. So we definitely recommend the use of insect repellents, and we recommend the use of insect repellents that are EPA registered, and that's very important because they've been tested for effectiveness and safety. There's a variety of different ingredients and products out there that have been registered by the EPA that have been shown to be safe and effective. DEET has been shown to be safe and effective for both children and adults, children over the age of 2 months old. A 30% concentration is really the most that you would need. The percentages merely mean how long it will last. So keep that in mind. If you're only going out for an hour, you may only need a 10%, but if you're going out all day, you may need up to a 30%. There is picaridin, oil of lemon eucalyptus, IR 3535. These are just ingredients that are EPA registered, that are in products, and it's really oftentimes it's person specific. It's person preference. There's also permethrin-based repellents that you can spray on clothing, and there's even clothing lines that are impregnated with tick repellent. But keep in mind that something like oil of lemon eucalyptus may sound safer than DEET, but actually it is not recommended for children under the age of 3. So you really have to look at the label, follow the directions on the label, and use it the way it's supposed to be used. Now, I use a combination myself personally if I'm going to work in the woods of protective clothing and using insect repellent. So I may spray, tuck my pants into my socks and then spray repellent around my my ankles. Spray around my any exposed skin, around my neck, my wrists, anywhere where I think a tick may end up. And I have had a tick on me from raking leaves and picking up leaves and throwing them into a wagon, and they just sort of flew down into my shirt. So using insect repellents, using protective clothing are going to be really important to prevent tick bites. And then the other thing is that you have to check yourself. You need to inspect your body for ticks, and if you find ticks on your body, you need to remove them. Now, so a daily check for ticks. If you have been in a tick environment, doing a daily check is going to be really important. So remember that that they're slow feeders, and it takes a long time for them to inject Borrelia into your body, 36 plus hours. So if you're checking yourself every day and you find a tick, then chances are it hasn't been on there for more than 24 hours. Showering, when you come inside after you've worked in the woods or gone hiking or worked in the garden, is good for a couple of reasons. It can wash unattacked ticks down the drain, and it also gives you an opportunity to check your body. Most people shower daily, that is a good time. There's usually really good lighting in the bathroom and mirrors that can assist you, and that is when that you can really check your body and check for ticks. Ticks need a certain level of humidity and moisture, usually inside of a house. They don't survive very well, so if a dog brings one in, they're not necessarily, they're probably going to die pretty quickly off of a person or an animal. You can also, for clothing, use high heat dryer. Will usually take care of it, or for camping gear. Stick it in the dryer, and that should take care of it. So tick removal. So the best advice that I can give you is to remain calm and be patient and get into a place where you have good lighting and that you're in the mindset of being able to do this task. Because if you yank and dig and use methods that aren't recommended, then you could get yourself into trouble. You could end up with a secondary skin infection. You could break the tick, and you want to be calm and you want to be patient. So fine tipped tweezers work very, very well. You want to grasp the tick with the tweezers as close to the skin as possible, as close to the mouth parts as possible, and then you want to use a steady motion. You want to pull away from the skin, and then you want to maintain that pressure, and then be patient and wait for the tick to release. You don't want to be yanking it. If you do that, you're going to break it. Once the tick is out, you want to clean the area with soap and water. You certainly want to avoid crushing it. And I have heard so many different methods that people have used to try to get ticks off of them. Petroleum jelly, using matches, nail polish, other products that really aren't recommended and can really get you into trouble. This is just some examples of tick removal tools. There's the tweezers, there's the tick spoon. The tick lister is actually entomologist recommended. The tick twisters, there's all kinds of products out there. If you don't have anything, a tool like this, you can certainly use the edge of a credit card to get that pressure and remove a tick. Tip from an entomologist right there. Landscape management, you want to assess, do an assessment of your property. Where are the high-risk areas? The perimeter between the woods and the lawn are where ticks are likely to be hanging out. They're going to be in tall grass. Where are your children's toys? Where's the swing set? It's probably not a good idea to have it under the trees, partly into the woods, but maybe out on the lawn where the grass is cut. Discouraging tick habitat, keeping the grass mowed, allowing more light to come in, trimming up branches on trees, managing host populations. That means that you may not want to have a bird feeder because a bird feeder attracts rodents, and white-footed mice is the reservoir for Borrelia bacteria. Deer fencing, not attracting deer, and then using insecticides. Tree fertilizer companies do this, and it has been shown to be very effective, and oftentimes one application is all that's needed. So keeping your grass mowed, removing brush and leaf litter, increasing the sunlight. We've talked about most of these things already. But again, do an assessment of your property. This can be done at the community intervention level for parks, for trails, etc.
So we're going to switch gears back and talk about some other vector-borne or insect-borne pathogens. And they are listed on the center, starting with Eastern equine encephalitis. And on the box, on the left-hand side, the yellow box, is sort of what all of these infections have in common. They are, first and foremost, very uncommon. They are spread predominantly by mosquito bites. There's one that is spread by a tick. In contrast to Lyme disease, these are viruses, particularly RNA viruses, and they're bad. They cause significant morbidity and mortality, and there's no treatment. So these, fortunately, are very rare, but unfortunately very bad. So we'll start with West Nile, which has gotten most of the press in the past 10 years or so.
So this is the West Nile virus transmission cycle. This is a mosquito-bird viral amplification process where mosquito, particularly the Culex species of mosquitoes, and certain species of birds that are competent hosts. And you get this back and forth amplification of the virus. And some birds tolerate this very well. They can, the virus is allowed to amplify without any morbidity or mortality in some bird species, but others not so much. And we do see, especially the corvid species, which are blue jays and crows and other birds that become ill and die from this. Now, this species of mosquito is not that fussy about where they get their blood meal. So they will bite birds and become infected with West Nile virus, but they'll also bite humans and horses. And if they're infected, they can transmit the virus to humans and horses. Now, humans and horses don't contribute to the viral amplification. They don't infect mosquitoes. They're considered end hosts. We've been doing surveillance since the year 2000 to the present. It's included mosquito pool testing. A mosquito pool is the same species of 50 or more mosquitoes that are pooled together and tested for virus. One thing that I'll mention about the mosquito pool testing is that early on there wasn't much of it going on. As years have gone by, it has increased exponentially with each year. So comparing year to year is probably not a good idea because the number of sites have increased significantly. We have done dead bird testing. We have collected dead birds and selected some for testing. That was discontinued in 2012. And certainly the veterinarians will do equine surveillance, and we've done human surveillance since 2000. Here is some of the data. I'm going to start at the bottom. So prior years, from 2000 to 2010, we had birds and mosquitoes that tested positive every year. In 2003, there was 3 human cases, 2005, 2 equine cases, and then really nothing until 2011, where we did see 2 additional human cases. 2012, 3 human cases and 2 horses. And 2013, we had quite an increase in the number of mosquito pools, but there was a lot more testing that was being done. 2014, 8 positive mosquito pools in Franklin, Orange, Windham, and Windsor counties. No human or equine cases reported. 2015, 35 positive mosquito pools as of September 5th. And I wanted to just say that that is out of 3,600 pools tested in 72 towns. And so lots of mosquito testing going on. So what does all this mean? It just means that we know West Nile virus circulates in Vermont. It has been shown to be in every county in Vermont, but no part of the state appears to be at a higher risk for infection. This is the national picture from 99 through 2012. 2003, there was a lot of cases reported with a resurgence in 2012. There was about 2,500 in 2013.
So this illness is quite rare, as Jeffrey was saying. Even so, most of the mosquitoes out there, and there are a gazillion of them, don't have this West Nile virus, and therefore most times that one is bit by a mosquito, you don't get this, so it's uncommon. The majority of people who, though, get this infection are asymptomatic. So they get bit by a mosquito that has West Nile virus in it, and they don't get sick. About 20% of the people who are bitten by an infected mosquito will get a flu-like illness, meaning sort of feverishness and achiness, sometimes a rash, but they will get better on their own. Rarely, somebody will get quite sick with this. And out of the people who do get infected and are systemically sick with a fever, of those febrile people, about 1 out of 150 will get a brain infection. And these can be quite serious. The majority have an encephalitis, or that the virus is actually in their brain tissue, and they present with headache, fever, and then seizures, coma, and the classic paralysis that can occur. The diagnosis is done by serologic testing, so we can't really grow this organism easily in the laboratory, and there's no treatment, so it is supportive care. So I think the message is very rare, but even if you do get bit, the great chances are that you will not get sick with this, but rarely it does. As you can see from the data Jeffrey was just talking about, there's been no cases in Vermont this year so far. So it is uncommon. Other vector-borne brain infections are listed there. I will talk about Eastern equine and Powassan. Those others that are listed there, St. Louis encephalitis virus, there have been no cases in Vermont recently. It's mostly in the central and western part of the United States. California encephalitis virus is out in the west. Western equine is out west also, and then Japanese encephalitis virus is on the other side of the world. So these, again, are very, very rare, but they can be devastating for that. So we'll take a look at Eastern equine encephalitis.
So this is a similar transmission cycle for Eastern equine encephalitis virus. It's a mosquito-bird viral amplification, similar to West Nile virus. The difference is that the mosquito vector is a different species of mosquito that prefers hardwood acidic swamp areas, which do exist in Vermont. The Culiceta melanura mosquito. This particular species of mosquito prefers birds, songbirds in particular. They seek out songbirds. They're not necessarily attracted to other mammals or animals for their blood meal. Although, given the opportunity and the question mark from this vector directly infecting a human or a horse, is at this point a possibility, but still a question mark. The other likely way that people and horses get infected is through bridge vectors, which are other species of mosquitoes that are more opportunistic in their feeding behavior. So they may bite a bird that is carrying Eastern equine encephalitis virus and then bite a horse or a human, and therefore transmitting the virus in that manner. We have done surveillance for Triple E, I'm going to call it Triple E so I don't have to keep saying Eastern equine encephalitis. There's been expanded testing of mosquito pools for the presence of the virus. Every year, blood testing of deer and moose for the presence of Triple E antibodies has been conducted. Opening day of hunting season, at checkpoint stations around the state, blood is collected from deer that are checked in. Veterinary sampling, veterinaries report suspicious cases or cases of in horses or other domestic animals, and certainly we've done human case surveillance. So what we've seen so far is that prior to 2010, we really didn't see anything. There were no reported human cases, there were no reported animal cases, and at that point in time, we were really doing very limited mosquito surveillance. Although we knew that it existed in other states around us, we had never seen it in Vermont. So from 2010 to present, we've done that deer serology, and those results have shown a wide distribution of the virus across Vermont. Virtually every portion of the state where testing was done, Triple E was found in deer or moose. In 2011, this was the first evidence of Triple E in domestic animals. This was emus in 2011. 2012, we got the first detection of mosquito pools and the first report of Triple E in humans. There were 2 cases, and unfortunately both were fatal. 2013, the mosquito pool testing increased significantly. 1,328 pools were tested, 22 were positive, primarily in Addison and Rutland County, which is where the largest hardwood acidic swamp exists, and also Franklin County. There were 2 horses in Franklin County that were diagnosed that year, and no human cases. 2014, again, a significant number of mosquito pools tested. Out of over 3,000, only 8 were positive, Chittenden, Addison, and Franklin County, with no domestic animal or human cases. And nothing so far this year except 1 mosquito pool in Swanton, and that is out of 3,600 mosquito pool tests.
So this is a bad infection. Incubation period, you can see, is about a week or a little bit longer. People then present with fever and headache as you would with any other type of central nervous system infection. But then over the next week or so, there's progressive neurologic involvement with confusion, somnolence. People can go on to seize, become comatose, and can get paralyzed with this. And the physical exam is essentially like any other central nervous system infection. There's depression of the sensorium. There can be cranial nerves, palsies and weaknesses. The neck may be rigid, and occasionally has been reported some edema. But it's a progressive, generally febrile neurologic deterioration that often, as Jeffrey had mentioned, leads to death. And the laboratory diagnosis is shown there. It's again by detecting antibodies in the blood. It is possible to isolate the virus from blood and spinal fluid, but that takes special laboratories. So this would be a diagnosis looking for somebody with a progressive encephalitic picture, profoundly ill, ICU level ill, where you can't find anything else, and you send off antibodies for testing. The treatment is supportive, and as Jeffrey alluded to, the prognosis is dismal. And then the last virus we'll touch on is perhaps even rarer. That is the Powassan virus. And in contrast to the other viral encephalitides, particularly West Nile and Eastern equine, the Powassan virus is spread by ticks, particularly the same tick that potentially transmits Lyme disease. It is very uncommon. The name Powassan comes from a town in Ontario shown on the map there where it was first found. And again, people would present as you would with all these other terrible central nervous system viral infections, headache and fever progressing to coma and paralysis. Again, the diagnosis is by serology. There's no treatment. And the case vitality rate is lower, meaning 5 or 10%, but a large number of people who do survive this are impaired. So this is nasty also.
So, in summary, we talked a lot about Lyme disease. So the take-home message is this is a bacterial spirochete, causes multi-system inflammatory disease by Borrelia burgdorferi. It's definitely increasing in Vermont and the Northeast, and diagnosis is based on characteristic signs and symptoms and this two-tiered testing. So be careful out there. Also, short course antibiotic treatment has proven to be effective. You want to watch out for co-infections with Babesia and Anaplasma. There's no evidence that prolonged antibiotics improve health, and that some of these chronic symptoms are common in the background of our culture. And definitely excessive antibiotics are dangerous.
And then finally, in terms of these really nasty vector-borne brain infections, they are mostly spread by mosquitoes, rarely ticks. They are rare, as you saw, and indeed in Vermont, in terms of West Nile, no cases recently, 2 cases of Eastern equine a couple of years ago, and none recently in Powassan, none. So they're out there, but they're very rare, but they're devastating, and there's no treatment, and the outcome is poor. So when you be careful about not getting Lyme disease, you be really careful about not getting these bad boys. And I think we'll end there. We may have time for questions if allowable.
I do see that there is one question in the chat box here. I'm just going to make sure. Any studies or knowledge about impacts of climate change on Lyme disease, West Nile, etc.? Well, I can comment on.
I can't get the chat box up.
Can I answer the question? Okay. Eastern equine encephalitis is particularly vulnerable to or dependent on season and weather conditions. And so when there is extremes of precipitation and drought, like we have seen in recent years, that is the kind of weather that mosquitoes love to breed in and keep those mosquitoes around longer. So yeah, I think that absolutely climate it influences some of these diseases. You know, there's also sprawl to consider. We're building more in areas where we didn't build before, where ticks are. We're building more in wooded areas. So certainly that has different land use also plays into it as well. And I don't see any other questions. That was very full.
this is Jean. I think this has been a very good presentation about a very complicated subject, and you have both been very thorough. I am imagining that participants may have questions later on as they have a chance to put all this together, and hopefully we could relay those to you for answers if necessary. I see thank yous but no further questions, so let me add to the thank yous for to both of you for the time and the care that you've put into this presentation. Because this is a new presentation to us to include in the agricultural medicine training, this is especially useful for us. So I thank you very much.
Well, you're very welcome. It was our pleasure to do this.
Yes, thank you very much.
Okay.